distance and things like that. I don't know whether the distance would be good enough if it's a 2 millimeter or 3 millimeter, but obviously 10 millimeter is better, much better than 5 millimeter, because of the moment of force will be 2 times. For effective rotation of a tooth, you will need around 1000 gram millimeter moment. Okay, 900 gram millimeter moment would be good, still good. But for sure, 200 gram millimeter is not going to be effective. You know that, right? You do this level of calculation. You do this level of estimation. Okay? Without drawing a line, you can never ever do this level of estimation. Where do you do that? From this, on the cephalogram, on the panoramic view. It's easy. Okay? Alright. After this session, you will be walking down to the lunch place, which is in the middle of a university main campus. That is around 5 to, not less than 10 minutes, 5 to 7 minutes walking distance. I'm sorry to have you walk through this humid weather, but yeah, we need a little bit of refreshment. And there you will have a little bit. I apologize to you because I didn't have a preliminary survey for your meal preference. Anyone vegan? Is there anyone vegan, very vegan? No? We had people from India. You don't have any India? You eat everything perfect. So there's no meal problem. Very good. Alright, thank you. And Totran, do you hear me? It's better for me to use this microphone, right? Okay. So I'll try to keep sitting on here. So, like I told you, these two are very different. These two are very different. At least 2 times difference. And the distance, what I mean by distance is shortest distance from the line of vector to the imaginary center of resistance. Okay? And this is a very simple calculation, but you can, well, at least estimate whether it will be effective or less effective. Now, here's the case. I asked you 2 questions. Why didn't I pull out the 3rd molar in the previous cases? And in this particular case, what tooth out of these 3 molars on the lower left side would have to be pulled out? Whether it's the 1st molar, 2nd molar, or 3rd molar. Second molar is troublesome. So it's better to pull out the 2nd molar. What do you think? I want to save your time, so instead of asking you a lot of questions, spending time discussing over and over, I'll give you the answer. First thing is the biomechanics. If you want to pull out the 2nd molar, you assume that you will pull the 3rd molar forward. Is that correct? What kind of tooth movement is that? Mesial translation. Also root movement. I'm sorry, I was going to draw a flat line. This is important. Again, draw a line. What does the line stand for? Occlusal plane. Your treatment occlusal plane. Very good. Very good. So according to the treatment occlusal plane, what kind of tooth movement do you need for the third molar if you pull out the second molar? First, mesial transfer, root movement, who said? Exactly. Do you understand? Root movement and intrusion. Is that going to be easy or difficult? Third option, terribly difficult, nightmare, you don't want to dream of ever in your life. I'll go for third option. Right? I mean, the answer is the third one. You don't want to do that. Okay? What about the third molar extraction? What do you need for the second molar? A lot of rotation. But like I told you, rotation is way easier, although it looks terrible, way easier than root movement. That guy gave us a right answer. Why? Because root movement and translation always takes much more amount of remodeling. Second thing is, it's not only about amount of bone remodeling, regulation about balance between the force and moment that I'm going to talk about later in the morning, also in the afternoon, is very difficult when it comes to root movement. But you can do that. After going through this lecture, you can try root movement arbitrarily, so you can be a much better orthodontist. Who else is doing the active root movement in the world? As far as I know, there's no one. There's no one. No one is challenging major root movement, either for incisor or the molar. They try, they claim that you can extend the lever arm to move the roots. Try it. Doesn't work. Nelson, she's a good friend of mine. But I'm not sure if she showed a major root movement. She's been away from the clinic for many years. Last month I ran into Dr. Nelson. We spent some time together talking about the suture, but we didn't have time to talk about the root movement. Next time I see her, I'll definitely go ask her, because I know she published some articles using multiple uprighting springs. If you remember, in the Journal of Clinical Orthodontics, that was a demonstration, but that was not about the mini spring. My point is, Dr. Nelson is able to try root movement. He must have shown some cases. But what I want to show you is the easier way, much simpler way, and much more drastic root movement. Okay? But by the way, I'm not competing with Dr. Nelson. We are always good friends, always good friends. We give a hug. Every time we see each other, we give a hug. Don't misunderstand this. And this is a thing. So resultantly, I'm not going to pull out the second molar. I'll go for third molar extraction, because biomechanically that's easier. Second, I'm terribly worried about the bone on the distal side of the first molar. What do you see? Already it's a defect because of the presence of the second molar crown. And once you make a decision to send the patient to oral surgery department to get the second molar extraction done, he will do it, surgical extraction. He will have to make a little bit of a defect to be able to remove the second molar. The first molar already has a defect on the distal side. If the defect increases because of the extraction of the second molar, the first molar will have some trouble. Do you agree? I am very serious about that, because if you lose the bone in the middle of the orthodontic procedure, all the complaint comes back to the orthodontist. The patient take their anger out on me, and you know that once the vertical bone defect is created, there's no way you can increase the bone. There's no way you can augment the bone in the vertical direction. should the tooth experience any kind of trouble, then, oh my god, not easy. Have a look at the bone defect on the distal side. Although it's minimal yet, so why don't I try something like this? What is important? To maximize the distance from the line of force to the center of resistance. And in this setting, although the degree of immediate angulation is very severe, just because we are not going to use maps, because using the maps, the distance will be minimal. Using the retromolar mini screw and lingual button position on the very distal top surface of the medial angulated second molar will create the largest possible distance. So, the position also important. Mini screw here will be better than here because I don't want to introduce very severe exclusive force factor. Okay? So, vertical component of force and the distance from the mini screw and the line of force must have to be taken into consideration. It's not just putting retromolar and button, a surgical opening. No, everything has to be taken into consideration. Question? Okay, that's a very good technical question. Just because there is a third molar, we ask for surgical opening and the extraction at the same time, and at the same time we will have to insert the mini screw in the surgery room, because we need to localize the margin of the extraction socket of the third molar. Without it, we can never ever place the mini screw. Right from the border of the extraction socket of the third molar, we'll have to keep a clearance of 2 or 3 millimeters in order to maintain the mini screw at sound bone. Do you understand? So when the surgeon opens the flap, then you can see everything, and the surgeon will do the surgical opening and pull out the third molar, and they will call us. I go into the surgery room and find the margin of the bone and everything, and insert the mini screw. And just because the soft tissue will be very thick, I insert the full length of the mini screw, confirm whether it's stable, and then I extend the ligature wire from the mini screw head this way, and then let him close the flap. That's the procedure. This is important. You are not supposed to insert the mini screw when the patient returns from the oral surgery department. You cannot see the margin of the extraction socket. That's reckless. So you have to do it all at the same time. That's a kind of a collaboration. So I describe this on the chart. You do the surgical opening and please call me. I'll go in and I'll do the insertion of the mini screw. Okay? But even before that, we have designed the force system. So I place an order. You please open the flap. I'm going to insert the mini screw right on the distal side. Okay? So let me do that. In this particular case, for some reason, the soft tissue on the distal side was not very thick, so we were able to keep the mini screw head open above the soft tissue. Rare case, but, and also have a look at the distance between the third molar spot and the mini screw. There is a clearance distance at least 2 or 3 millimeters. Okay? So the mini screw is inserted on the sound bone. Now we are trying uprighting of the second molar. How long did it take? 5 months? Oh my God. 5 months. So the answer for this particular case, which tooth should we extract? The answer is the third molar. Okay? Because of the easiness of uprighting second molar. And secondly, if you pull out the second molar, there must be a lot of vertical bone defect that will not go away. They will be retained for the rest of their life. And second thing is intrusive root movement of the lower third molar is possibly the most difficult type of tooth movement in the world you can ever imagine. You can still do it. I will tell you how, but very challenging. Still, there's a woven bone on the distal side of the first molar. Let's have a look. Before and after. See, the bone level on the distal side of the first molar is very well maintained. But as long as the bone is covered by the soft tissue, as long as you have the intact mesenchymal cells in here, there will be bone recovery over time. This again. Initial. No, it's too fast. Oh my gosh. One. It's automatic. Oh my god, I don't like this. From here, have a look at the lamina dura. Between the first and third molar, okay? We expected something like this. So we were able to finish this case in this way. Good alignment with a good bone healing. Okay. Finally, I'll have to answer the very first question. That question is related to the question I asked you before the coffee break. Why didn't I pull out the third molar in the previous cases? Why didn't I pull out the third molar? In this case, I pulled out the third molar because I had to insert the minuscule on the distal side. I had to do it. And what do you see? What do you see in here? Space between the first and third molar. As soon as the third molar is uprighted, because the crown is moving like this, it is very natural that you see space between the first and the third molar. Space between first and the second molar. Sorry, space between the first and the second molar. Why? Because it's moving like this. But it didn't really concern me very much in this case because it was supposed to be a comprehensive orthodontic treatment. I was going to put the braces on. I was going to use a continuous arch wire to close the premolar extraction space and things like that. But in the previous case, just because it was a very partial orthodontic treatment case, I had to use the third molar as a fulcrum. This way, for uprighting movement, center of rotation is found a little below the center of resistance because we have applied distalizing force. But if you have a third molar right on the distal side of the uprighting second molar root, this will resist the distal movement of the crown in a sense. So you can achieve molar uprighting without any space between the first and second molar. I'm not the one who created this theory. Dr. Melson described it in one of her articles. Use the third molar as a fulcrum. That's sometimes very useful, especially when you are worried about the space between first and second molar when you upright the second molar. Do you understand? The same thing for for this case. First thing, we were going to use a minuscule on the medial side, and still we were worried about the space between the first and second molar. So we didn't pull out the third molar from the first place. Only when we uprighted the second molar up to this point, we send the patient to the surgery department, make that extraction done. So you take advantage of every possible anatomical structure you can ever imagine. Do you understand? By the way, isn't it exciting to know about biomechanics? Everything, every step of the procedure, every appointment, whatever you do, that has the reason. And that's interpretable. Sometimes it doesn't work that way. Sometimes it doesn't seem to follow my order, but you can still interpret what was wrong, what was not very enough, what was not really sufficient, and you can do the troubleshooting. That is a power of knowing biomechanics. So, even if the tooth moves to an odd direction, you can still interpret, okay, my force may have been a little bit excessive, deficient. My moment may have been a little bit excessive or deficient. This is important. And you can troubleshoot the situation. Question?
Professor, this one is to open the bite, so like a bite break to help the movements.
So the question is, did I have to open the bite or raise the bite to be able to upright the molar?
Yes.
My answer, you should never ever do that. You should never ever do that. When it comes to molar uprighting, I would strongly advise you not to use a bite razor, bite jumper, or whatever you may call it. You never do that. Why? First, because it was supposed to be a partial orthodontic case, except for the mesio-angulated second molar. Everything else was okay. People would expect, okay, what I would do is to simple uprighting. But if you use a bite turbo or bite razor, whatever it is, all of a sudden many patients, majority of patients develops bad habit like tongue thrusting because there's occlusal, interocclusal clearance. I showed you one case before this to show you the possible side effect of conventional root spring. Why is this happening? Bite opening, transverse problem, and everything before and after. Because the patient develops, when there's an occlusal interference, patient feels that it's a little different. Patient develops different mastication habit, tongue thrusting, and different swallowing pattern, and then all the pressure is reflected on the lateral side of the teeth, and the incisor open bite develops. That it's the beginning of the nightmare. You don't want to experience this. So many times when I give a lecture, it's compared to you do the restoration, right? Let's say you do class 1 cavity, occlusal side, class 1 cavity. You go deeper and you run into pulp chamber. Oh my God, by accident, it becomes a root canal treatment case. Was supposed to be class 1 O cavity. Now you developed root canal treatment. And you do the root canal treatment. In the meantime, you make a hole, you have a puncture by accident at the base of the pulp chamber. Oh my God, the tooth becomes hopeless. You develop the hopeless tooth case. It evolved from O cavity to a dental implant case. Isn't it miserable? Was supposed to be a very, very partial orthodontic treatment where you just attach only a couple of braces and things like that. But as soon as you raise the bite, that's the beginning of the nightmare. That was a very good question. We should not miss that. We should not miss that. Do you understand? Whenever you try a partial, so-called partial orthodontic case, I would strongly advise you not to use a bite razor. So what's the alternative? In through the molar. In through the molar. I'll talk about it. Okay?
How about anatomical considerations when you don't have a third molar? In this case, you have a surgical exposure of the bone. You can place it very safely. But in the cases where you don't have a third molar, but it's still a degenerated second molar, how would you orient yourself anatomically
Then you,
to place it?
well, then you basically have to assume that you're going to need a minimum attachment after uprighting the second molar, because you might be seeing the space between the first and second molar. You will try partial attachment from 4, 5, 6, 7 continuous arch wire for the sake of a space closure of a tiny little space.
Anatomical considerations of the meniscus without a surgical flap. Or in the electromolar area.
Ah.
Is there any anatomic landmark that you go at before you
One second, just because there's a question. This is my suggestion. Example of retromolar meniscus insertion without third molar extraction. You palpate the area of the distal side of the second molar. It's not the very distal side of the second molar because that's a void, that's a vacant. External oblique, which is found on the distal buccal area on the distal side of the second molar. So it has to be distal buccal side. Okay? Then you pick up the meniscus of 7 or 8 millimeters. Then you start insertion with a straight screwdriver. Straight screwdriver, that's accessible. Then still the question is whether you have to try to expose the meniscus head or not. If you want to expose the meniscus head, then majority of the meniscus body will be exposed on top of the bone surface, right? So it's not stable. Instead of that, I would advise you to insert the whole length of the meniscus in the bone. Then the meniscus head will be submerged. Right? On the same day, without flap reflection, you can still barely see the meniscus head. So, try insertion this way with the direct application. This is not good enough. Do a little more insertion up to this point. Now the whole length of the meniscus is in the bone. Now when you are able to barely see the meniscus head, extend the ligature wire from the meniscus head. So the next morning, in a day or two, the whole meniscus head will be covered. Disregard the alarm, it's nothing. Meniscus head will be covered by the soft tissue in the next day or two. You can still use a pigtail to engage your power chain, to be able to engage your power chain. This is what we call closed technique. This technique is applied to all of the retromolar meniscus and submucosal insertion of the meniscus and things like that when you run into a very mobile soft tissue, okay? Instead of using very long meniscus with very long superstructure, you insert a 7 or 8 millimeter meniscus on a regular basis, but try to insert the whole length of the meniscus in the bone and extend the ligature wire from the meniscus head to be able to engage your power chain. That's a reasonable advice, isn't it? Okay? Which wire? 010. 010. It's not very strict recommendation, but 010 is normally good enough to resist retraction force. What do you find from this clinical picture? Crowding, midline deviation. What else? Class 2 molar relationship on one side. Lower right, second molar, first molar seems to be angulated. That's it. That's it. So this is the thing. This was the situation. Probably the most terrible situation. Basically, you want to pull out the first molar. Very natural, very natural. If you pull out the first molar, then everything will be solved. No, it's not solved. Why? Because you will leave a very huge bone defect. There already was a bone defect. Already was a bone defect on the distal side of the second molar. So it's not an issue about the first molar. It's an issue about second premolar. What does it look like? Just like this. You want to pull out the first molar? Yes or no? What you can do is that you just let the surgeon pull out the first molar, and don't let the patient come back to your clinic for the life, for the rest of the life. You don't want to see the patient because you have to be responsible for the mobile, very wobbly second premolar, and you're not supposed to do anything about the vertical bone defect. And you will take the responsibility because you place an order for the extraction of the first molar. I'm very sorry to talk about this nightmare, scary scenario you can ever imagine in your clinic, but this happens, right? This happens. Your decision today will give you a nightmare for the next year or two, maybe for the lifetime. So the decision you make today is very important. Do you agree? Now, you don't agree? Do you agree?
Yes.
Thank you very much to be my side. So, I don't want to pull out the first molar. As long as the first molar is not enclosed, second molar extraction will be good choice, very good choice. In what? From a biomechanical standpoint. Well, first molar looks terrible, but it doesn't mean that it's difficult to move. What kind of tooth movement do we need to save the first molar? If you want to save the first molar, rotation, distal rotation, right? Is it a very difficult type of tooth movement? Yes or no? Not really. Not really. Not really. So it's going to be relatively simple. So do not be fooled by the way it looks. It's terrible. So what are you going to do with the terrible tooth? Don't panic. What you need, okay, if you pull out the first molar, you will be in deep trouble. If you pull out the second molar, you'll have to struggle with the first molar. Are you going to be struggling? Biomechanical is not really difficult. So, and one clue is that not easy to tell whether it's enclosed or not, but you will try whatever possible clinical measures around you. You can try after opening the flap, you can try a period test or some trial movement or something, but that doesn't really help. If it's a vertical impaction without any cause or etiology, it's probably enclosed. If it's a mesial angulation and the first molar has an obvious reason for the impaction, which is a blockage by the second premolar, so the chance of enclosis is reduced. And then you can try. second molar extraction. Using the mini screw on the distal side of the third molar, you apply a single force on the crown. Okay, single force on the crown will create a moment of a force. It will rotate the first molar to the distal side. Like this. How long does it take? Maybe 5 or 6 months. Wow. Why? Because the mini screw is so superb? Because Dr. Lee is so powerful? No, I don't think so. It's a simple rotational movement. It takes place in so short period of time. Much faster than the root movement. Much faster. So we simply replace the second molar with the first molar. So the clinical picture is exactly same as initial. That's funny. We spent some time, but clinical picture is exactly same as the initial one. What's the payoff? What's the payoff? Well, from now on, we're expecting to see bone formation on the distal side of the second premolar. That's the payoff. So we're not worried about the possible bone defect in this particular case for the rest of his life. See? This is it. This is a huge amount of tooth movement, but from a biomechanical standpoint, it's relatively easy. So you can deceive people out there because it's so dramatic. So dramatic. Hey, have a look. I use this and that brand mini screw, and this is so powerful. Have a look at the amount of tooth movement. And you won't believe your eyes. This is because of the type of mini screw brand I'm using. Oh my God, this is something else. Huh? This is all about biomechanics. By the way, do you feel cold? Still cold? 선생님? 얘기했어요? So the rest of the treatment will be regular premolar extraction to match the midline between top and bottom, and space closure, and the whole treatment was finished in this way. Class 2 molar on the right, class 1 molar on the left. Initial, final. Once again, initial, final. We are very happy about not only about alignment, not only about midline coincidence, not only about occlusion, but also this one. You can ever, do you think you can ever imagine a specialist in the dentistry who will do this work better than orthodontist? Vertical augmentation. That's not possible. I mean, I ask the same question to my periodontist or a maxillofacial surgeon if they can do vertical augmentation of the interradicular bone in this way. No, they can't. They can't. Because artificial bone augmentation always is subject to bone resorption and possible inflammation, bone loss over time. Not easy. Never easy. But we take advantage of biology. Biology. We left the area wrapped up by overlying soft tissue, and there must be a lot of mesenchymal cells, natural mesenchymal cells and everything, so you won't have any problem, and you don't have to do any surgical procedure. Okay, so that was it. And for the secondary major ambulation, now this is going to be a little tough. This is going to be a little tough. Why is it tough? Because it looks so simple. It looks so simple. Now the patient was referred from a prosthodontic department for the sake of a molar uprighting over here. The space was a little deficient for the dental implant, so he wanted us to upright the second molar. Well, very simple. Very simple. You can try MAPS, mini screw assisted push spring, right? Yes or no? Are you concerned about something else? You concerned about something else? So we were going to use the maps. 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 Is that going to work? Is maps going to work? Yes or no? No. No, it's not going to work. Why? Why? Because the second molar is in the way. Are you going to use a bi-turbo, bi-jumper for this molar uprighting case? Yes or no? You should never, never ever use a bi-turbo. Please don't do that. If you want to do that, I will keep following you. Whether you're in Brazil, Argentina, I will keep following you, saying, praying that you should never do that. Please don't do that. Please don't do that. Please don't use a resin, composite, turbo, whatever it is. Please don't do that. Don't do that. You must be in trouble. You must be in trouble in the next month or two. What else do you do this? Preliminary intrusion. Preliminary intrusion would be more than maybe the solution. Just because it was a palatal cusp that was in the way, and you don't want to spend a lot of money. You want to minimize the number of the mini screw. You become stingy. So you insert one mini screw between 6 and 7 on the palatal side. But then again, you have to understand, single mini screw on the palatal side would produce not only intrusive force but also medialized force. Do you understand? Lateral force to the medial side, not mesial side, to the medial side, to the midline, right? That's a very tremendous transverse lateral force. So have a look. This was aligned before you apply the force. Now have a look at the discrepancy between 6 and 7 in the transverse dimension. This happens. So basically, you should have placed the mini screw both on the buccal and palatal side to be able to intrude the second molar without any tilting to either direction. Do you understand? So this is a kind of a biomechanics, not very sophisticated. You know something and try to refine your information in your mind just a little more. You used to say you need a tipping, but what did we discuss yesterday? To specify the type of tooth. It has to be a little intrusive tipping to be able to maintain the overbite and overjet. The same thing when it comes to molar uprighting. You need a very conservative movement in the meantime. During the molar uprighting, the uprighting molar should never be interfered with any object. What do I mean by object? Maybe counterpart molar, which is upper molar. Alright? Please keep that in mind. And there's another biological reason that I emphasize this. So, preliminary intrusion. See, initial, and after a couple months of so-called intrusion, I noticed there's a discrepancy on the buccal side. I had to use another mini screw. Should have been mini screw on the buccal and palatal side from the first place. Anyway, we were able to get rid of the possible interference, and then I insert the mini screw on the distal side to be able to upright the second one. Did I use a bi-turbo in here? No. And you take the impression to check and confirm that there's no interference on the way of the uprighting molar. So this is a difference, okay? You need something like this. Without the mini screw, this kind of a conservative, minimum type of tooth movement is hardly imaginable. Hardly imaginable. You need a little bit of a fine-tune adjustment, and now you just stabilize the segment of the arch and have a look at the space between the second premolar and second molar. Uprighting without any interference, without any trouble. Now, fixture is given. crown. Occlusion is perfect. So this is the sequence of the treatment. Even if the molar uprighting in the lower arch was demanded, you still need to do something on the top to be able to do the molar uprighting. And now you check the occlusion both from the buccal side and the palpar side. Do you like this? Yes, it's okay. Now, let me talk a little bit about intrusive root removal. Here's a 37-year-old male. Initially, so technically it's not always easy. Initially, the prosthodontist wanted us to upright the molar to create a space between second premolar and first molar. Okay. Not easy to upright the second molar without extraction of the third molar, right? But just because we noticed that the second premolar was in full class 2 position, was not only about molar uprighting, but also mesialization of the second premolar. Okay, let's try molar uprighting without extraction of the third molar. We tried by mesializing the second premolar and disalizing in second molar. We created a space. Okay, so what does the literature say? If you find a mesialized molar, uprighting the molar will benefit the periodontium. Is that correct? Just because it's mesialized? Uprighting is good for the periodontium, good for the alveolar bone. Is that correct? Yes? So we are instructed, or we are advised to upright the molar at all times, because mesialized molar will be really terrible, especially on the mesial side. Let's have a look. Initial. What happened? Did I benefit the alveolar bone? Did I improve the alveolar bone? Strange. Maybe I did something wrong. I don't know. Then again, the patient all of a sudden changes his mind. Hey, Dr. Lee, I went through the internet, and then they say it's possible to move the molar forward. If that's possible, then I don't need to have the dental implant for the rest of my life. Why don't you try something like that? So it's definitely a typical example of a round tripping. It should not be done in this way, but just because the patient changes his mind, and I also expected to see some change on the alveolar bone. So it's not a desirable sequence of the treatment, but we tried mesialization of the molar. Mesialization of the molar. Using the mini screw between 4 and 5, we pulled the molar, second molar, all the way forward, and barely we were able to close the gap between the second premolar and first molar. The whole thing took me more than 3 years. So it's a bad example, not a good example, but now what happened? Oh my God, I'm a little frustrated. So we want to find the cause, main reason for the alveolar bone. What do you think? Have you any opinion about this whole sequence of the treatment? Should have been this and that way. Do you have any suggestion? And why did this kind of loss of alveolar bone happen? Have any idea or suggestion? Huh? Yeah, I'm talking about the periodontal support. We lost. And why did we lose it? You're talking about extrusion, but we are always taught to try exclusive uprighting of a medialized molar in the orthodontic literature, isn't it?
No, you can use two cantilevers and do intruded and outside.
Why?
Because you not do the front and front of the ball. You will do first
So she's talking about elimination of the round tripping. Okay, that makes sense. But still, I'm curious why we struggle with this loss of alveolar bone in this particular case. Just because we upright it first and then move the molar forward. What do you think? Yeah, there always is osteoblast and osteoclast collaboration. No matter what you do, I mean, without osteoblast or osteoclast collaboration, we cannot do anything. This is a relevant article. I like this review, and in the middle of the review, have a look at the second line. In 60% of uprighted molars, there was an increase in the distance between the mesial CEJ and the adjacent crestal bone, indicating extrusion or mesial bone loss. Extrusion leads to loss of alveolar bone. Extrusive molar uprighting leads to loss of alveolar bone. Why? So, there are two things: extrusion, trauma, very bad. Okay? You lose the bone. And second thing, I am the cell. I am the cell over here. Try uprighting. I am here. I am the cell. I am supposed to make bone over here, but my tooth is running away from me. Is that correct? I have to crawl over the root surface to follow the tooth. Can I do that? Maybe yes or maybe not. So this kind of a movement away from the site makes it hard for the cells to crawl over the root surface to make the bone. Do you understand? Okay? Cells are not Iron Man. They don't fly. Cells, they stay still and they are supposed to make bone only when the environment is really quiescent. You know what? What I mean, the quiescent, very stable, steady, right? So, if you move the bone, I mean, if you move a tooth in this way, first thing, they will experience trauma, and this part will experience the scaffold moving away from you. You are not supposed to fly over to the root surface. So it is very natural that you lose the attachment over here. Do you understand? This is totally opposite from what we learned from contemporary orthodontics. We are always advised to upright any mesialized molar, but in the meantime, you will experience loss of alveolar. Are you shocked? You must be shocked. Oh my God. I've learned a totally different idea, totally wrong idea. But that's true. You know what? Very few orthodontic programs really teaches the biology. I'm really sad about it. I feel sad. Why? Because biology doesn't seem to help orthodontic treatment, but it helps for us to avoid any possible side effect from happening. From biological standpoint, you're not supposed to upright this molar by exclusive rotational movement. Instead of that, in this article, the authors suggest instead of this, maybe you can try fixing this point this point, something like this, right? What is that? Intrusive root movement. Is that possible? Is that possible? He suggested, and we realize it, we produce it. So what do you mean? Intrusive root movement or intrusive uprighting. Dr. Nelson used two cantilever springs to produce intrusive uprighting, but not necessarily intrusive root movement to the medial side. I propose an intrusive root movement. Using I'm going to have to explain this further. First, continuous arch wire. What kind of force would this second molar experience would feel? Rotation first, rotation, okay? Extrusion. How do you know that? Huh?
Geometry 2.
Third, geometry. There's a very good understanding of the geometry. But for those who didn't have a good understanding of the geometry, I made a small gadget over here. I'll leave it on the table during the lunch break. Please play with this. Try to simulate this thing. Simulate this thing, okay? Exactly the same. And you will see your right hand. Right hand, which is simulating the visualized molar. Your right hand must be pressing the wire down to maintain this relative position, which means your right hand will feel extrusive force. Okay? This is a static equilibrium. I'm going to make a long story short. Please play with this during the lunch break, alright? You can try any kind of rocket geometry with this. So this tooth will experience extrusion and possibly rotation. And this causes traumatic occlusion. Very bad. So in reality, if you use a continuous arch wire to be able to upright the molar, first, if you are lucky, it doesn't work. If you are lucky, it doesn't work. It doesn't move. And what is the worst case scenario? If you are unlucky, what happens? First, traumatic occlusion. Second, alveolar bone loss. Third, creation of open body because of occlusal interference. Oh my God, isn't that very terrible consequence? Very terrible. Okay, Dr. Lee, I'm going to use a lever arm. I've learned that lever arm will create a very low level of force vector that will enable us to try root movement. There's a finite element there. If it's above, the blue line indicates medial root movement or distal tipping. If the plot is above the zero level, it means the root movement. Tiny little amount of root movement only when you combine hook 5. Hook 5, the longest hook combined with the most occlusal minuscule. So it has to be this way. The vector has to be this way. It makes sense because this way you can maximize the distance between the center of resistance and the line of force. It makes sense, okay. So it has to be a combination between hook 5 and minuscule number 1. No, it's not correct. It is correct, but it doesn't make a lot of sense because you introduce too much extrusive force factor. No good. No good. Okay? So you'll experience the same problem. Alveolar bone loss, traumatic occlusion, open bite, and no movement. By the way, we found that we localized the center of resistance in the lower molar segment and published, which was published in 2019. So this will be included in your suggested reading. You have the Google Drive, right? So please refer to the article. And I'm going to make a long story short. Not easy. You need a constant moment together with the intrusive force. Have a look at the case first. Medialized second molar. We wanted to get rid of the extraction spot, extraction space. We used a dual mini screw with a helical spring. What does it do? What does it do? What first? What is our target center? This is second molar. What is the force system doing? First, intrusion. Rotation. Okay? Intrusion and rotation. If you use a tooth-borne anchorage, I mean, there's no way where you can introduce intrusive movement. You need to use a. So this is similar to the helical spring that I introduced to you in the morning. 2 mini screws, helical spring, rotation. So there's no side effect at all. There's no side effect at all. And bone level on the medial side is very well maintained. Okay? We didn't lose the bone. In the meantime, we also used a slight intrusion of the upper molar to be able to have some clearance between upper and lower molars. This is important. We never ever raise the bite when it comes to partial orthodontic treatment in adults. Oh my God, I saved you a lot of money. If you have a lawsuit with your patient, it's going to take your money, tremendous amount of money out of your pocket, right? I saved you $1 million. You earned $1 million today. Aren't you happy? Aren't you happy? It's a lot of money. So, fabrication of a mini screw assisted root spring, MAH05964. Everything is fabricated on the chair side, basically you don't need to take any pressure. Insert a mini screw, first one. Insert a mini screw, second one. And you can bend the wire. That is on the table over here. Well, we have only 10 steps. You can try an insertion during the lunch break, but don't lose it for the next person. It can be inserted in the slot very passively. It has to be passive. And if it's passive, try to feel the initial force system the tooth may experience. You become the tooth, and then insert the wire. The initial force system that the second molar would experience will be pure intrusion. Is that correct? Pure intrusion. If you don't get it, try to, okay, this is what we call activation force system. To engage the wire, what kind of force system did we need to be able to engage the wire? Pure extrusion, right? If this is pure extrusion, the activation force system the tooth will experience in response to a wire will be pure intrusion. That's this deactivation force system is equal and opposite to the activation activation force system. And then the activation force system is the force system that is given to the tooth that will initiate the tooth movement. So, if you understand the deactivation force system, now you understand, okay, the tooth will sense what kind of force system? Toward intrusion as the initial force system. So it will be intruded. And then, if you let it go, by constantly reactivating, then the root will come forward. What is the precaution here? What is the precaution? You produce moment, and then in the meantime, if you produce constant moment, the crown will come backward, go backward. You don't want to let this happen. So what do you do? Okay? You got it? Buckle inclination? Sometimes it happens. So you do one thing at a time. One thing at a time, alright? So this time, for example, you have a very serious buccal tilting, I would advise you to align, linear alignment or something like that. You cannot possibly try a buccal lingual movement and medial distal movement at the same time. That will be very complicated. So try one thing at a time. Okay? Spring size is a 1622 stainless steel. My wire sequence is very simple. It's either 16 round stainless steel or 1622 stainless steel. That's it.
Professor,
I don't use a lot of wire sets. Remember, one second. Remember, this power chain must be minimal. Okay? Do you understand? This power chain must be minimal. I'm going to use the same principle for the incisor root movement that will be applied to non-surgical treatment tomorrow morning. Okay? So if you don't get it today, you still have a second chance. Question?
when the molar be intruded, the geometry switches from 4 to 5, so the moment it generates itself, it's not by us. Do we have to create the moment, or just let the tooth intrude and then the geometry switch from 4 to 5 and we have the moment?
Does it create geometry 4 or 5? I don't understand.
No, I mean when the tooth intrude, the first one is geometry 4, and then when the tooth intrude,
Okay.
it switches to
If
the
I understood
geometry
your
5.
question correctly, this is geometry 2. I'm going to explain the geometry a little more in detail in the afternoon. Geometry 2. Geometry 3. Bad example. If you intrude the lower molar, even before you operate the lower molar, if you intrude it, it creates geometry 2, but not 4 or 5. You understand? It's geometry 2, not 4 or 5. Okay? So in this situation, you can even use a continuous arch wire, but in order to eliminate the side effect, I would still advise you to use a mini-screw assisted something, mini-screw assisted spring or something. Trauma from occlusion. So, Mars, constant intrusion, and root movement. Have a look at the interocclusal clearance. This is what is important. Interocclusal clearance. This is important. You should never ever use a biturbo. Never do. Never do. And then root comes forward gradually. If you assume a treatment time for molar uprighting to the distal side as 6 months, root movement of lower molar to the medial side will take you at least 2 years. 4 times difference. Root movement Then why would I try root movement? Because patient likes it. Patient likes it, even if it takes 4 times longer treatment time. Patient likes it. Why? Then they don't have to have the dental implant. They choose. They really choose. Okay? So there's a lot of patients who come from the local clinic and prosthetic department expecting for us to close the space by root movement and things like that. Although it takes time, they choose it because they don't want to have an artificial object in their body. Not from the beginning, in the middle. You have to keep an eye on the distance. If it's too much space, then you use a minimum couching. Or you can use a ligature time, because it doesn't create active force. Yes. Yes. Sorry? You will have to reactivate the spring. Yeah, but not the power chain, but you really have to reactivate the spring. According to the experimental setup, you have to do it every month. Because every degree, imagine you have a 45-degree medial angulation. Let's say you upright this by 3 degrees in 1 month. You still need a 1,000 gram millimeter moment. Every 3 degrees molar rotation, you need 1,000 or 1,000, a couple hundred gram millimeter moment, for which you need to reactivate the helical spring. All right? Okay, so that's a similar question. If you move the molar, if you change the angulation, the geometry changes. Okay, so let me answer one question. Just because we are not relying on the tooth anchor, it doesn't affect the geometry between the two teeth. And you're talking about the geometry between the mini screw and the attachment, right?
Yes, but you're activating to have a movement and the force and intrusion. That's specifically for the fourth geometry, right? This is what it is.
Fourth geometry? You think so?
It's passive on the, you said it's passive on the past.
Okay, let me answer the question. To make to simplify that, you regard this as a shape-driven appliance. Shape-driven appliance, all right? Because the minuscule is not supposed to move. So, in the meantime, eventually you will have an excessive intrusion of the second molar, but that's okay, because if you have enough intermaxillary space, then it's a very good room space for the molar to move to any direction, and it doesn't really affect the biology and it doesn't affect the alveolar level. So even if it's a very excessive intrusion, it doesn't really concern me. Okay, and this is compared to a little different from the conventional geometry. I know the geometry changes according to the molar operating, but just regard this as a shape-driven appliance. So this will follow all the way the way the spring is deactivated, then this is still okay. Uprighting? This one? The appliance? What is important is you have to have a combination of a weak force, large moment. This is important. Okay. The guy in the back, you asked me about the equivalent force system, right? So we don't, just because we don't measure the amount of moment every time, what really matters in terms of an equivalent force system is the way how the balance between the force and the moment. What is this kind of root movement? What do we need? don't know, but weak force, the large moment. Weak force and the large moment. Try to maintain the force as low as possible. Try to maintain try to keep the amount of moment as high as possible. As far as I know, lever arm is not going to produce enough moment of force because center of resistance is located at very low position. Okay? If you want to design a mesial root movement of the molar, you better not try lever arm. You better not try lever arm. So this is an example of equivalent force system. You try, you give some force system on still the bracket level, which is very high compared to the level of the center of resistance, but just because you produce very high moment with a very weak force, you are able to move the root forward. You are not able to move the root with the lever arm. Don't be fooled by the way how it's described in literature, in the article. They are very deceiving, I have to tell you. So, if you use a single mini screw without uprighting spring, you cannot control the vertical displacement of the crown.
If you want to put the steel ligature, then you will just have a rotation, and you will not have an extrusion. If you have a steel ligature,
In this here, still you cannot possibly control the vertical because the crown, even if you tie it up, the crown will come out. Do you understand?
you control it easily. You can move
Yes,
easily,
yes.
but not distally.
Yeah, you can control the medial distal movement of the crown, but not necessarily in the vertical direction. It's better for you to use a dual mini screw if you are very much concerned about vertical displacement of the crown. Okay? If you still want to use the single mini screw, then it's better for you to preliminarily intrude your motor. I mean, no matter what, the bottom line is that you keep the occlusal clearance between top and bottom, especially when you deal with adult cases, all right? So, this was published in 2009, ankylosis of the lower first molar. Like you said, just because she was still growing and there was some occlusal clearance, you can try with a single mini screw. You can try and monitor the situation for the first 3-4 months of time. And if you believe the molar movement is interfered with by the upper molar, then you can think about adding one more mini screw. You can try this kind of sequential approach. This may work, and this worked with this particular case. Maybe because her bite force was not really heavy. She was 15, teenage. After extraction of the ankylosed first molar, we tried the mesial root movement of the second molar, and it worked. And finally, we were able to match the top and bottom of class 2 and class 1. And bone defect is completely gone, which is the best possible result of orthodontic treatment. I'll show you one more case and we'll go for the lunch. Are you starving?
Yes.
My God, you're good. I'm giving lectures in almost all parts of the world. And I'm really thankful that my lecture is normally well attended. I mean, I'm not talking about the number of participants, well attended. Very few of them are sleeping in the lecture. The only exception is that Yonsei University students, they sleep. So I was curious if my lecture is really boring. And I asked them, is my lecture really boring? after I go to another country, nobody really sleeps in the middle of the lecture. So I convince myself my lecture is not boring. I'm still confused because my students are sleeping all the time. 9-year-old girl with an ankylosis, obvious discontinuation of the pelvic ligament. Something should have been done when she was 9. Nobody did something in 2 years really badly. So this is what she looked like. First molar in here, second molar, complete class 2 because of the ankylosing the first molar. Gradual migration to one side, complete class 2 canine. We need to convert the situation, right? Crowding, midline deviation. First molar, very terrible. Draw a line. What kind of tooth movement do we need for the second molar? We can draw a flat line over here. Flat line. Sorry. Flat line. Let's say this is your treatment of occlusal plane. How much movement do we need for the second molar? If you want to pull the second molar forward, isn't it unbelievable amount of intrusive root movement of the second molar? It is normally impossible. Right? Do you agree? Gentlemen? Do you agree? It is unbelievable amount of intrusive root movement of the second molar, so it's better not to do anything. Better not to do anything. Or second alternative, second option is to send the patient to your neighbor orthodontist who is not in good relationship with you. Very good policy. I can introduce you to a very good orthodontist. You want to try? I'll write down your address and try this orthodontist. He's good. Or she's good. So, this is it. You're not supposed to try intrusive root movement if she was 20 something. If she was turning 11, maybe we can try. Relying on her, some possible bone remodeling. In order to relieve the burden, we decide to intrude the molar, upper molar as well. Molar intrusion. Relatively easy. Molar intrusion. Preliminary molar intrusion. Have a look at the tremendous intermaxillary gap between top and bottom. Then we try single helical spring. Single helical spring. Mass to produce active torque. Active moment. Let's say active moment. We upright it, following the instructions of the first molar. Still we need to try major movement to the medial side. Really major. The greatest major on top of a high majestic, major. 14 years, we were able to align, match the top and bottom at class 1 molar. How much movement did we get out of this? If you simply compare the position of the second molar between initial and final, if we did the superimposition, it was not 20 millimeter, 18.5 millimeter mesial displacement of the second asked her why. Because she was young enough. She was young enough. Okay. So the amount of tooth movement is definitely inversely proportional to the age. High age, less movement. Low age, more movement. So if you plan something, this is reckless type of tooth movement. Impossible, but if you want to try something radical, try it before it's too late. So that determines your clinical decision. That helps your clinical decision. Young, more, aged, less. We decide to try radical movement because she was young and we did it. And finally, the more exciting thing is because we are still expecting the third molar to erupt, and it's seriously mesioangulated. Just because we got rid of an obstacle on the mesial side, we had to keep an eye on the third molar for the next 5 years. My God. Well, compared with the right and left side, it's blocked. It's blocked. It ended up with a mesial ambulation, but the other side, although we had to do a little bit of alignment for a couple months, erupted at the right position in the next 5 years. What does it mean? Without the obstacle on the mesial side, the third molar has a potential to erupt well. Does it make sense? So it's worthwhile to try this kind of radical mesial root movement of the second molar all the way forward by 18 millimeters to help the third molar eruption. Does it make sense? So whenever I see this girl, I'll keep telling, hey, I'm your hero. Do you know that? She doesn't understand. How else can I explain this? It could have been $30,000 treatment fee for your lifetime. Then I think the parents would be going, oh my God, it's so worthwhile. Dr. Lee, thank you so much. I have to explain everything at a treatment fee standpoint. I don't know why she developed a little bit recession over here, but overall, she has a very good consequence and also complete dentition from the second molar all the way the other side second molar. Perfect. Okay? And I'm going to talk about the inclusive root movement of the upper molar after the lunch break. This is possibly the most difficult type of root movement. Okay? Is it enjoyable? Any question? Yes. Until what age? That's the most difficult question. I recently tried a major root movement of the upper molar in 60-year-old gentleman, which took me more than around 4 years. Rewarding, but I had to experience a major bone loss on the parietal root and things like that. Well, it is still surviving, but I think that kind of radical tooth movement can be tried in your 20s, not even in 30s, right? In 30s, you really have to have a very good reason for it. If the patient really feels reluctant about family plan and things like that, you can negotiate with the patient. The amount of tooth movement decreases over time, right? So that kind of tooth movement is best indicated in the early 20s, mid-20s, late teens, right? Any other question? So you will have a lot of questions, but let's eat first. Then you can play with this small gadget over here during lunch break, and we'll keep talking in the afternoon. And we'll also have a very important hands-on session in the afternoon I'll guide you how to insert the minuscule in the interverticular area, because we talk a lot about interverticular minuscule before we go, right? Okay, please enjoy lunch. You will be guided to the lunch place. Now, thank you. I hope you will be returning by 1:30 in here.
Cái bạn cái thành việc của mình đó, cái xong cái đó thì em ta sẽ gọi ví dụ ăn cái số bằng số 24 cái đời sống mình tập đời sống sinh viên như này chị nhắn lên group đó mọi người quá động lên group, tại vì ví dụ như nó có A là cái gì, B là cái gì, C là cái gì, thì mình mình được chọn một món ở trong đó, nó bự lắm á. Còn nếu mà các bạn phân với nhau, các bạn sẽ chọn cái món lệch nhau để phân với nhau thì gọi đó. Thì trên ví dụ cái số của riêng đây là đang là số mấy đây, số 2, số 3, số 7 thì Liên đưa cho người ta nửa cái riêng còn lại cho có cái lời viết đâu có cái lô đây hả?
Cái này là 2 ngày hả chị?
2 ngày phải cách thử sau người ta phát nữa. Tại mấy ngày kia mình ăn
Em nghĩ là răng dưới nó thì đánh núi nó đi gần tâm cả.
mình sẽ ghi
Sao?
em tưởng
Có tỏ âm sẵn rồi.
ngày nào cũng cả ngày
Cái này là 8 có 3 một điên. Răng trên cơ. Nào nó để suy nghĩ chương trình thấy cùng rồi là cái
rồi đó nên là các anh chị đọc
Mày đi học có phải mày đi ăn đâu? Là béo vậy rồi ăn đi.
em coi trong cái tờ chương trình nhá. Không có bây giờ thấy cái kết thúc cái chương trình đó. Để đồ đây.
đi bây giờ theo mình chứ anh bỏ
Đi đâu vậy đây?
Ở trên trong ông baby.
Đây đi theo mấy ai này nè, đây là